We have the interesting series presentation now. We have 8 presenters. We have 5 minutes for the presentation and 2 minutes for the discussion. They will be given marks by the judges here based on the complexity of the case, the innovativeness in doing the case, the presentation and the discussion. Total score of 10 marks. And we call in the first presenter, Dr. Islam from Madras Medical Mission.
Good afternoon, respected chairpersons. My case is concurrent endovascular repair of multi-level aortic aneurysm. 60-year-old lady with hypertension for 15 years and diabetes for 6 months developed pulmonary tuberculosis, for which she was put on ATT and recovered with mild fibrosis of the right upper lobe. Post-PT treatment, chest X-ray revealed a dilated thoracic aorta, hence a CT scan was asked for, and the CT scan showed this multi-level aneurysm. She had a large aneurysm of the entire thoracic aorta starting just after the left subclavian, and only a small portion of area from the origin of the celiac to the renals was normal, and again after that infrarenal aortic aneurysm extending into the right iliac and also into the right internal iliac. Surgeons refused to operate, and hence endovascular approach was considered. So we read the literature. Previously they have done this kind of extensive aneurysms in either a hybrid setup or they are staged it. But this we did in a single stage. So challenges to endovascular approach in this case was, she was a small fragile lady, so the access artery was not of adequate size. Normally you need at least 7 millimeter of femoral artery, which she didn't have. So there was an inadequate access for her. Then she had a very long thoracic aneurysm and no stent graft comes in this length, so you will need 2 overlapping stent grafts for the thoracic aneurysm. She also had an inadequate proximal neck of the thoracic aneurysm, meaning we will have to protect the left subclavian by a chimney technique. Fourth, there was an inadequate proximal neck of the abdominal aneurysm, which meant that we might need to jail the renal artery, left lower renal artery. Fortunately for her, she had 4 renal arteries, 2 on the left and 2 on the right. So to get a good waist, we would have to sacrifice the left lower renal artery. And then there was a 90-degree angulation of the lower end of the thoracic aneurysm, so we had to choose a graft which will adapt to this curvature. And there was a very large and long common iliac aneurysm extending in the internal iliac, which meant that we would need to cover with an extra graft there and also see to it that the internal iliac is coiled, otherwise it will cause an endoleak. And then we are covering off almost the entire aorta, leaving a small segment in between. Normally when we cover more than 200 millimeters of the aorta, the chances of spinal ischemia is high, and so here we had to cover almost 400 millimeters of the aorta with stent graft. So for the inadequate access size, we took 3 axes. On the left side we took an extraperitoneal conduit. The surgeon had to open the abdomen and then connect a graft to the external iliac. On the right side, we had taken a percutaneous puncture of the right femoral artery, and a left brachial was also taken to deliver the chimney stent for the left subclavian. And since whenever we are covering a large segment of the aorta, we need to see that the subclavian is patent because it supplies collaterals to the spinal arteries, and hence we had to do a chimney graft of the left subclavian to preserve the left subclavian artery. And since we had inadequate neck of the abdominal aneurysm, we had to seal the left lower renal artery. Luckily, it was not supplying a very large portion of the left kidney. So some amount of renal necrosis might be anticipated. The hardwares that we used were 5x8 1 and 5x5 2 coils for embolizing the right internal iliac artery, 2 Valiant stent grafts for the thoracic aneurysm, 1 abdominal aneurysm stent graft Endurant, and a right common iliac extension graft, and a chimney graft with the atrium 8x38 covered stent. So first we selectively from the left side intubated the iliac, then went into the internal iliac and coiled it with the 5x5 and 5x8 coils so that the internal iliac artery was totally occluded. And then through the percutaneous brachial approach, we kept in a multipurpose catheter with a wire into the subclavian for delivering the chimney graft, and then a pigtail was introduced through the right puncture and a shot taken of the aneurysm. Then we delivered the distal stent first, and to place the stent exactly above the celiac and the renals, we placed a wire into the renal arteries, showing us the level at which we should be. And then the lower stent graft 13 to 169 Valiant graft was deployed. And then through the deployed stent graft, 36 into 219 millimeter graft for the thoracic aneurysm was taken through the abdominal stent graft, and then the stent graft was deployed, before which we placed the chimney graft in the left subclavian through the brachial approach. The stent graft was deployed first, and then the atrium stent was deployed, and then final kissing inflation of both the Reliant balloon and the atrium balloon was done. And then for the infrarenal aneurysm portion, an endurant bifurcated stent graft was taken. It was 23 millimeter at the upper end, 16 at the lower end, and 139 millimeter long. And here also, to mark the exact placement, we had placed a wire in the right lower renal artery so that our stent should come below this. And of course, it would be jailing the left renal artery. So the stent was deployed, the ipsilateral arm was also deployed, and then a contralateral arm was deployed. We knew it would be short, falling short, because the aneurysm in the iliac was long, and you can see that there is endoleak occurring through the internal iliac. So we needed an extension graft for this. An extension graft was put, and then this is the final picture showing the stent well opposed, no endoleak, and this is the lower end of the abdominal aneurysm, and the iliac flow on both sides was good. Following extensive coverage of the aneurysm, one should see to it that the arterial pressures are kept up. Spinal ischemia which can occur depends on the difference between the mean pressure and the spinal pressure. So one has to keep the arterial pressure up. Unfortunately, the patient's lower limb pulses were not well felt, and the surgeon wanted us to start on NTG drip for the lower limb. But we could not allow that, because if the mean pressure falls to 70, then the chances of ischemia are high, where we have almost covered more than 400 millimeters of the aorta. So we refused to start NTG. Our pressures were, being a hypertensive, her pressures were on the higher side only. So, but afterwards, after 24 hours, the pulses came, and that gave us a relief. So after 1 month, we did a CT, which did not show any endoleak. With the renal artery, we could see both the kidneys well preserved in spite of jailing of one left lower renal artery. And at 6 month follow-up also, the patient is doing fine, and there is no endoleak. So thus a complex EVAR procedure which required tackling of 3 aneurysms, thoracic, abdominal and iliacs, was done in one sitting. Extraparenteral condylar access was needed. Coil embolization of the right internal iliac artery was needed. Chimney graft for the left subclavian artery was needed, and an extension graft for the right iliac artery's long aneurysm was needed. Need for stent grafts and 1 extension graft to cover the entire aorta from left subclavian to iliacs, and covering of almost 500 millimeter of the aorta with increased risk of spinal ischemia was done in one sitting without any complication and a good result. Of course, the cost was high. So complex multilevel endovascular aneurysms can be closed by UR at one sitting if due importance is given to the prevention of spinal cord ischemia. And we had this published in Heart, Lung and Circulation also. Thank you.